that in the presence of optimal anti-HER2 therapy, you may be able to reduce a little bit on the toxicity of the chemotherapy.
Thank you very much. So following my first questions, we understand in HER2 positive disease, there is a strong impact of PCR on patients' outcomes, and the adjuvant continuation of pertuzumab plus trastuzumab is the optimal treatment of choice for patients with PCR. So from your perspective, what would be your suggestions for those patients without achieving PCR after surgery?
Well, the current clinical standard, if you don't have a PCR, is to switch to TDM1. That would be the standard of care in Germany. We do have clinical trials available. That is always my first option if we have a trial to escalate even further. And there's a couple of trials right now ongoing. I think I would put the patient in the trial, but TDM1 is our preferred choice. And that doesn't matter whether the non-PCR specimen is HER2 positive or HER2 negative. We know from the Catherine trial that you can have a benefit with TDM1 either way. So just in case some of your pathologists, it's better to continue with the dual blockade than to de-escalate there or don't give any therapy. So the data from the trials like Affinity or Caitlin, where we gave 18 cycles of dual blockade after surgery,